So, welcome to the 8th episode of the second season of the Medicrew Masterclasses, where we discuss handpicked topics on neuropsychiatry. And today we are going to talk about the anxiety spectrum disorders, including obsessive and compulsive disorder. So, as usual, before we start, we'll start with a few multiple choice questions. And after attempting those questions, we'll discuss the topics over and again get back to the same questions to review our understanding. Let us start with the first question. This is your first question. True about neurotic disorders is. So, which statement is true about neurosis? Next question. Trypanophobia is a fear of what? Next question. So, carefully read the case history. A person experiences sudden onset chest pain and a feeling of impending doom. The symptoms develop all within 10 minutes. On examination, no medical cause could be identified. A similar episode occurred 2 weeks ago. So, what is the probable diagnosis? Next question. Again, we have a short case study. A college student starts feeling extremely awkward and anxious while entering common spaces like canteen or common rooms, or when getting up on the dais to speak. What is the probable diagnosis about this college student? The next question is, an obsession is. So, what is the best description that suits the definition of obsession? Next question. Flashbacks are characteristic of which disorder? Moving on to the next question. Stage fright or performance anxiety is best treated with which drug? And now comes the last question, after which we start the discussion. There are two statements. Read them and then choose the correct option. The first statement reads, Selective serotonin reuptake inhibitors are first-line drugs in treating anxiety spectrum disorders. And the second statement says, while prescribing SSRIs for anxiety disorders, a benzodiazepine should be added for the first few days. Now choose the correct option from A to D. Okay, so with these introductory questions, let us start our discussion on anxiety spectrum disorders. Now, we know that people in general have anxiety. Anxiety is one of the primary emotions of human being. So we often experience anxiety, we worry about things. Sometimes these become so persistent and inappropriate that they can be regarded as an illness. Now, in the first few episodes, we had delineated two important terminologies in psychiatric nomenclature. One is psychosis and the other is neurosis. Neurosis or neurotic disorders refer to those kinds of disorders that do not present with hallucination, that do not present with delusion, or an impairment of judgment or insight. So the person is, quote unquote, mentally sound and aware of the condition, but is also suffering. Typical examples of neurotic disorders are anxiety spectrum disorders. Unlike schizophrenia, which is a psychotic disorder, in neurotic disorder, judgment and insight is never impaired. It is always intact. And delusion and hallucination are extremely rare to find in a true case of neurosis. For simplicity, we will classify the features of any neurosis into four domains: the emotional domain, cognitive domain, behavioral domain, and the somatic domain. So the emotional domain will talk about the feelings, how the person feels. Cognitive domain about the awareness of the individual to the surrounding and the self. Behavioral domain is about how the person behaves. And somatic domain are the physical symptoms like palpitation, dry throat, tremor, etc. You will see that almost all anxiety disorders can be very easily described with the help of these four domains. So, in general, in neurotic disorders, as I was saying, anxiety is the primary emotional component, whereas the cognitive components are worry, fear, and concern. Abnormal behaviors include avoidance. For example, if you are afraid of snake, you will be avoiding snakes. Or other strategies like repeated checking. If you are obsessed about locking the door, then you will keep on repeatedly going up to the lock and check whether the door has been locked properly or not. The somatic or the physical symptoms in general in anxiety are associated with tension, sympathetic nervous system activation, and hyperventilation. So just to give an example of these four domains, say for example, neurotic disorders may present with an emotion of anxiety. For example, during a panic attack, the person feels extremely anxious and feels like the person is going to die. It may also present with one of the other symptoms like cognitive features, like excessive worry or thinking about a disease. It's something that happens in hypochondriasis. A person is obsessed about thinking that the person has a disease. The person will search up the internet, look into books, start finding new diagnoses to fit his or her condition. It can also be an inappropriate behavior. For example, if a person is agoraphobic, then the person will not try to be in a position from where escape is difficult. For example, the person will try to avoid very crowded places. The person will try to avoid a cinema hall. The person will try to avoid being on a flight for long distance from where easy escape is not possible. And there may be somatic symptoms of anxiety like palpitation, tremor, and dry throat, which are usually features of sympathetic overactivity. So most anxiety disorders have these common features. The way we divide them is based mainly on the stressor, what causes the anxiety. When you come into the classification of the stress related neurotic disorders, we find that most psychiatric bodies will classify them under three main headings. The typical neurotic disorders, which are also known as anxiety spectrum disorders. The second category is the stress related disorders. And the third category that presents with physical symptoms mainly, that is called somatoform disorder. Today we will discuss in detail about a few of these, which are more prevalent and more common. But before we go into a discussion of that, let us in an outline understand what these individual nomenclatures mean to us. Anxiety disorders all have in common the features of being anxious. There is excessive worry and there are physical features like tremor, palpitation, etc. And today we will discuss all the three important anxiety disorders: phobic anxiety, panic disorder, and generalized anxiety. Another neurotic and often included under anxiety disorder is obsessive compulsive disorder. We are also going to discuss in detail about obsessive compulsive disorder. We will understand why a person has a ritualistic tendency to repeat an activity again and again. Some less known but obviously much common disorders include dissociative disorders, where a person may be detached from reality or may start thinking that the person has been possessed by someone, often to vent out certain stress. Chronic fatigue syndrome, which is a feature of chronic non well being, not related to any known medical conditions. And rarely depersonalization, derealization syndromes, where a person feels that he or she is not in control of their own body. Stress related disorders can be acute stress reaction that happens soon after some stressful event. Adjustment disorders that typically affect relationships. Disorders of adjustment with the family, with the spouse, in the workplace. Or it can be a post-traumatic stress disorder, where you have flashbacks of memory of a very hurtful event that happened in your life. Then comes the somatoform disorders, where the person does not actually complain of any cognitive impairment or increased worry. The main concern of the person is physical. So the person will complain of unexplained illness, of pains in different part of the body, of dysuria but with no evidence of urinary tract infection. So these kind of physical symptoms may be reported by the patient, and even after thorough investigation, no medical cause can be found out. These category of disorders are known as somatoform disorders. So these are, in a nutshell, the chief kinds of neurotic stress related and somatoform disorders. And we will discuss a few of them today under anxiety spectrum disorders. I hope up to this it is clear to everyone. Okay. So how do we approach a neurotic disorder? Because the features of neurosis are so much in common with sympathetic overactivity or other features like features of thyrotoxicosis, features of pheochromocytoma, etc. So it's always very important that before landing up on the diagnosis, you should rule out the probable medical differential diagnosis. So there are two very important questions you must ask yourself before landing up on a diagnosis of neurosis. Do the patient's symptom warrant any diagnosis? Now, this is a subjective question, but is a very important question. As I told you, anxiety is a very basic and primary human emotion. It's not wrong to be anxious. Sometimes it is very appropriate to be anxious. The situation demands us to become anxious. So if a person is in a congruent way anxious in context with some really tough situation, that does not always require a diagnosis. If the life of the person is not dysfunctional and the quality of life is maintained, and the person has some degree of anxiety, you may make no diagnosis at all. And it is actually very important for a mental health specialist to know when not to make a diagnosis. However, if you really think that it impairs the quality of a person's life and the life is getting dysfunctional and you want to make a diagnosis, ask the second question. Is there an alternative diagnosis that can be more appropriate? That means you rule out the organic causes that can mimic the situation. For example, rule out causes like hyperthyroidism, rule out other endocrinopathies, rule out the effect of certain drugs that can cause palpitations or dry throat before landing up on a diagnosis of neurotic disorder. When these two questions have been successfully answered, you can definitely go for a proper diagnosis of the neurotic condition. One very important kind of anxiety spectrum disorder is a specific phobia. The name specific tells you what it is. It is a persistent fear of a specific object or situation. And the key word is which is out of proportion to the threat of the situation. For example, you are watching a cockroach and the whole imagery of a cockroach walking around gives you crawls and creeps all over your body. But you can understand and rationalize that of course a cockroach cannot kill you, cannot harm you. Rather, you are a bigger threat to the cockroach than the cockroach to you. But still you are afraid, which takes us to the second point. The fear is recognized as excessive but cannot be reasoned away. So you understand that it is excessive, but you cannot reason your mind and ultimately get the fear out of your mind. So this kind of quote unquote irrational fears of an object or situation is known as specific phobia. There are hundreds of specific phobia with complicated nomenclature, and we will not get into the trivia of that. I will only discuss some of the common specific phobia that we experience and see in our day-to-day lives. Acrophobia is the fear of heights, and it's one of the most common specific phobias that individuals have. Claustrophobia is a fear of enclosed spaces. For example, to be inside a phone booth or to be placed inside an MRI machine. This kind of closed atmospheres will trigger panic. That is called claustrophobia. Entomophobia is the fear of insects. Ophidiophobia is a fear of snakes. Cynophobia is a fear of dogs. Astraphobia is a fear of storms. And trypanophobia is a fear of needles. Don't confuse the name with trypophobia, which is a fear of holes or perforations. Agoraphobia is a kind of phobia that is often misunderstood. Sometimes we say that agoraphobia is a fear of a crowded space or fear of an open space, often contradictory to each other. But none of these are properly speaking definitions of agoraphobia. Agoraphobia does not discuss the openness of the place or the closedness of the space. Agoraphobia refers to the inescapability of the situation. That is more important. So the space can be open, the space can be closed, the place can be crowded, the space can be empty. Doesn't matter. But you cannot readily go out of that place if you want. That is a criteria. And if that triggers panic in you, that is agoraphobia. So I'll give you an example. Suppose you are boarding by a flight. Of course, you cannot jump from the aeroplane. So anytime you want, you cannot escape from the flight. So if it is a flight destined to be a journey of 3 hours, you have to be seated for 3 hours in your place. Now let us assume that the flight is relatively empty. It's not crowded, or it is crowded. Irrespective of that, if you have a panic that you cannot go out of the flight, then that is agoraphobia. Because it's a fear of not being able to escape. Or suppose you are in an examination hall and the rule is that you cannot go out of the hall before 1 hour. If that triggers panic in you, then that is agoraphobia. Suppose you are in a very empty space, but there are no vehicles around. There is no transportation system. So again, in an empty space, you cannot go out or leave the space at your will. Maybe you have to wait for 3 hours for a bus to come. Then if that triggers panic in you, that is agoraphobia. So what I'm trying to say is, unlike the popular perception of agoraphobia, it is not about open space or closed space, crowded space or empty space. It is about the inescapability from the space or situation. So it is an anxiety associated with places or situation from which escape may be difficult. like crowds or public spaces which have very limited mobility. Avoidance of the situation is a very prominent feature. The person knows that this will trigger panic, and that is why the person will usually not go there. Even if the person goes there, the person often takes with him or her some other people who do not have the agoraphobia. In the language of psychiatry, sometimes this second person is called a phobic companion. So they require a phobic companion to go with them to the place of distress. And it is strongly associated with panic attack. It is the fear of panic attack for which the person is avoiding the place. So again, if I divide them into the four domains that I said, the emotional component of agoraphobia is anxiety that can be triggered in closed spaces like shop or crowded places from where escape is not easy. The cognitive component is a thought of collapsing or being helpless. Behavior is to avoid the situation. And the somatic symptom will be all symptoms of panic like palpitation, dry throat, tremor, diaphoresis, etc. It is often associated with panic disorder. It is so much so associated that in ICD-10, agoraphobia is classified into two types: agoraphobia with panic disorder and agoraphobia without panic disorder. And with panic disorder is actually a more common diagnosis. Social phobia is the persistent fear of social situations in general, not specifically related to one person or two persons. So when we are going out to eat, drink, or speak in the public, face the stage, or go out to a restaurant or a party, suddenly the person freezes and feels very awkward. And this is often associated with sensitivity to criticism, and the people may have avoidant personality disorder. They get distressed at other people looking at them and judging their appearance and behavior, and from there stems the social phobia. So it's a fear of being in a public place where other people are also present and being totally uncomfortable in such social situations. So again, if you categorize them into the four domains, the emotional component of social phobia is a situational anxiety when you are in social gathering. That can be an academic gathering, that can be a celebratory gathering, that can be a mourning gathering, any kind of gathering. The cognitive component is the fear of being judged negatively by other people. So the behavior is to avoid such social occasions. And the somatic symptoms include the features of embarrassment like blushing and trembling. Sometimes this can lead to secondary alcohol misuse because the person would like to distract him or her from such a socially embarrassing situation. Panic attacks are very dramatic in presentation. They can mimic myocardial infarction, they can mimic cerebrovascular accident, they can mimic seizures. But on medical examination, none of them will be found to be present. So these are episodes of severe paroxysmal anxiety, all associated with somatic symptoms, and the person thinks that they are not in control of their own body. This is called depersonalization or derealization. You feel that your body has totally given up on you and you can collapse at any point of time. Usually attacks develop within 10 minutes of time, and they can be triggered by situations like agoraphobia. In panic disorder, the attacks are recurrent. So if there are more than one attacks in 1 month, the panic attacks will be then called panic disorder. The somatic symptoms, as I told you, may be severe and lead to a misdiagnosis, like angina, epilepsy, or other medical conditions. That is why to diagnose panic attack correctly, you have to clinically and also through investigation rule out the possible medical causes. Again, if I categorize panic attacks into these four domains, the emotional component is a severe incapacitating anxiety. Cognitive component is a fear of dying or going mad or otherwise losing control over yourself. The behavioral component is to escape from the situation. And the somatic components are all symptoms of sympathetic arousal, like tremor, like palpitation, and like feelings of impending doom. And as I told you, they're often associated with agoraphobia and sometimes with depression. Now, these conditions that we discussed so far are triggered by specific incidents, and therefore many of them are called specific phobias. Whereas if a person is anxious in general, not related to one particular situation, then that is called generalized anxiety disorder. So it is a generalized and persistent anxiety, not restricted to or confined to any particular circumstances. It's also therefore known as a free floating anxiety disorder. That means you are always anxious. You don't require a reason to be anxious. The lifetime prevalence is found to be around 5%. Females are more commonly affected than males. And the onset typically happens in adolescence to early adulthood. To diagnose generalized anxiety disorder, we have three categories of criteria. The first criteria is excessive worry for 6 months about a number of events and activity, not something specific only. The second point is that the person finds it difficult to control the worry. And the third criteria demands that there should be at least three criteria of the following 6 points: restlessness, fatigue, poor concentration, irritability, raised muscle tension, or sleep disturbance. So at least any three out of these six should be present with options A and B. And then you can diagnose generalized anxiety disorder. So if I categorize the components of generalized anxiety into the domains that I am doing, the emotional component is of a overwhelming anxiety. The cognitive component is excessive, disproportionate, uncontrollable worry. So you cannot stop worrying. You're always worrying about everything. Starting from examinations to finances to your relationships, everything is creating worry in you. The behavior is that the person is often on the edge and easily startled. So you are so alert and anxious that even if someone calls you by the name, you will start having palpitations. The somatic symptoms include various diffuse features without any medical cause, multiple chronic aches, headache, tension, sweating, and it may be associated with depression. So it's very important to know that anxiety and depression can coexist in the same person, and they are not opposites of each other. They are actually on the same side of the spectrum. Post-traumatic stress disorder is a particular kind of intense, delayed, and prolonged reaction to a very stressful event. It is typically triggered by traumatic events like a violent road traffic accident, or seeing someone getting murdered, someone dying very tragically in front of you, experiencing warfares, and a large number of such cases were reported after the Vietnam Wars. The image here in the inset actually is an image from the Vietnam War victims. Many of the soldiers developed post-traumatic stress disorder. A central feature is that the person will keep on either dreaming about the frightful events or have flashback memories of the frightful event. So they keep on re-experiencing and having flashbacks of the event that triggers anxiety in them. And that typically leads to an attack of panic. This is known as post-traumatic stress disorder. Obsessive compulsive disorder is a very interesting situation. It is definitely an anxiety disorder. The person has recurrent distressing thoughts coming into the mind. And these recurrent distressing thoughts are known as obsessions. So, obsession refers to the recurrent distressing thought that a person might have. On the other hand, compulsion refers to acts that are done repeatedly to relieve anxiety. I'll just give you an example of what this means. For example, a distressful thought in your mind is that your hands are always contaminated. They're always contaminated with dirt and bacteria. This thought is always coming in your mind. Because it's a thought, therefore, this is the obsession. And this thought process makes you wash your hand again and again. This washing the hands again and again is an activity that gives you temporary relief from the thought that your hands are contaminated. And this is known as compulsion, because this is an activity. Often obsession and compulsion forms a pair. Like a fear of contamination is coupled with washing hands. A fear of insecure door is coupled with repeated checking of the locks. A fear of making mistake is associated with repeatedly checking calculations and score sheets or balance sheets. So often they go hand in hand. But it is not necessary always that there has to be a pair like this. Even a simple obsession or compulsion, when present alone, can be a feature of obsessive compulsive disorder. Sometimes it is associated with an undeniable urge of making odd sounds or gestures, something that is known as a tic disorder. And sometimes there is a genetically predisposed tic disorder running in the family, something known as Tourette syndrome. Sometimes there is an uncontrollable urge of pulling out hairs and occasionally ingesting that. This is called trichotillomania. Similarly, there may be an uncontrollable urge to pluck the skin from the body and consume it, which is often called dermatillomania. These are often associated comorbidities that can exist with obsessive compulsive disorder. So as I was saying, the obsessive compulsive cycle is a paired cycle, and this is a kind of model that can explain obsessive compulsive disorder. So there is a stimulus, internal or external, that often leads to obsession and distress. The stimulus may be reading about germs. This leads to the obsession of hands being always contaminated. This causes distress and anxiety. So to remove that distress, you develop a technique or a ritualistic behavior that may be repeatedly washing hands. This becomes your compulsion. It gives you a temporary relief from the anxiety, but it is only temporary. Instead, it also reinforces the behavior, telling you that it is the right thing to do. So again, when the thought comes back to your mind, you keep on repeating the same thing again and again. And an obsessive compulsive cycle will go on and on. So is this cycle of obsession and compulsion clear to everyone? Okay. So again, if I break it up into the four domains, the emotional component of OCD is anxiety about the topic of obsessional thought. The cognitive domain is preoccupation with obsession. The behavioral domain is the compulsion, the activity that you keep on doing again and again. It may be associated with somatic symptom. If you are not allowed to do the compulsive act, then you will be starting to have building up of tension. That is why this activity is said to be an ego dystonic activity, an activity that you also yourself do not like to do. And the associated disorders, apart from Tourette syndrome or trichotillomania, can be depression and a kind of personality known as anancastic personality, which is a obsessive compulsive personality, which may be associated with OCD. So to understand the pharmacological basis of the treatment of anxiety spectrum disorders, we must have to know how anxiety happens. Like most psychiatric disorders, our knowledge about the pathophysiology of anxiety is very sparse. We really do not understand that much. But there are hypotheses that there is a monoamine deficiency very similar to what happens in depression. There may also be reduced GABA in the brain, causing increased arousal. Also, there are theories that the hippocampus and cingulate gyrus causes a very bad processing of threat signals, keeping us always alert when there is no need to be alerted. Also, we know that amygdala is the place where fear is generated. Maybe the prefrontal cortex unnecessarily generates fear by its connection to the amygdala. So many hypotheses are there. It's difficult to stitch them together into one unified theory, but I'll try doing that using a model that has been developed by the author Yan Yu. So let's step by step put things together, trying to make a working model for anxiety disorders. There are certain known stressors like the female gender, which may be due to social predisposition that they are more prone to anxiety. Uh, Genetics, because it can often run in families. And there are some other theories also under further investigation. All these things somehow cause imbalance of monoamines like noradrenaline, serotonin, dopamine, and GABA in the brain. Due to disorders of these neurotransmitters, the hippocampus and the cingulate gyrus abnormally process threat signals that come from the environment. So a signal that is actually not frightful is seen as something frightful. One of the causes why phobia probably develops. Additionally, the prefrontal cortex causes a wrong modulation of the amygdala. As a result, amygdala activates fear response, often without any reason. Again, this is the reason why irrational fear is a component of many anxiety spectrum disorders. These ultimately cause stress response. We know there are two stress hormones in the body. The acute response is mediated by adrenaline and the chronic response by cortisol. So both these axes are activated. Activation of the hypothalamo-pituitary adrenal axis causes increased cortisol, whereas the activation of autonomic nervous system and adrenal medulla cause increased epinephrine release. And these in the long term will lead to sympathetic features, and they will also in a very complicated way interact with the brain, causing some permanent changes. Ultimately, the outcome is a bad processing of fear, an abnormal processing of threat, an overall increased adrenergic response, and an overall hypercortisolic state, leading to anxiety disorders that will be characterized by physiological signs and symptoms, unpleasant tension, and a sense of foreboding or apprehension that something bad is going to happen. This is a linear model. Let's see how this can get complicated by vicious cycles. Because of the chronic activation of the stress hormones, cortisol and adrenaline, there is also untimely death of certain neurons in the hippocampus. We know hippocampus has an important role in regulation of memory as well as mood. So hippocampus can no longer properly integrate environmental stimulus, further causing abnormally processed threat signals. And so this becomes a vicious cycle. Because of the death of the neuron in the brain, the neurotrophic factors or growth factors decrease, causing long-term damage to the neurons. And as I told you, because hippocampus is important in regulating mood as well as the consolidation of memory, so there is also mood dysregulation and memory impairment. And it is actually not surprising that depression and anxiety can happen together, because the monoamine mechanism and the areas of the brain affected are very similar rather than different. Luckily, therefore, drugs that are used to treat depression can also be used to treat anxiety. So, if this is the sole model of anxiety, what are the areas that we can target for therapy? The chemical imbalance can be treated with monoaminergic drug, like the selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, etc. Or we can also correct the imbalance due to gamma aminobutyric acid symptomatically by giving GABA receptor agonist like benzodiazepines. The increased adrenaline release and thereafter the sympathetic response that it produces can be controlled largely by using beta blockers like propranolol. Along with this, overall features of anxiety can be partly cured symptomatically by anxiolytic drugs like the azapirone class of drugs. So we actually have very limited number of drugs and none of them cure anxiety. They only treat anxiety symptomatically. So the drugs that can be used to treat anxiety disorders can be classified in this way. Some drugs will relieve the subjective symptoms of anxiety, like palpitation, insomnia, etc. These include anxiolytic drugs like benzodiazepines, diazepam, clonazepam, lorazepam, and azapirones like buspirone. Then we also have beta blockers like propranolol. They are wonderful in reducing tremor, reducing palpitation, reducing the frequency of panic attacks, and propranolol is a wonderful drug for stage fright or performance anxiety. Monoamine deficiency in the brain can be corrected by selective serotonin reuptake inhibitors, tricyclic antidepressants, or serotonin noradrenaline reuptake inhibitors, or with newer atypical drugs like mirtazapine or bupropion. However, it is seen that when we use the drugs, for the first few days, anxiety level can paradoxically worsen. That is why for the first few days of using these drugs, it's important to add a benzodiazepine along with the anxiety treating drug. So for example, escitalopram and clonazepam or fluoxetine and clonazepam are very common combinations that are given in the beginning. Gradually, the benzodiazepine can be stopped and we can step up the dose of the SSRI or the SNRI. Non-pharmacological therapies include anxiety management strategies like psychological education, distraction techniques, cognitive control, and breathing and relaxation techniques. So there are different kinds of relaxation techniques like Jacobson's progressive muscle relaxation. They can be taught by proper therapists and practiced by the client. We can also do cognitive behavior therapy to address the inner fears and dysfunctions. And exposure and response prevention therapy is particularly important for phobia, where you are gradually exposed to your component of threat and gradually you are learning to control the response to this. And this gradually develops as a habit, and you can overcome the phobia by exposure and response prevention strategies. So these, in a nutshell, are the principles of treating anxiety spectrum disorders. So up to this, is this clear to everyone? Okay, so let's get back to the questions that we started with. True about neurotic disorders is. Yes, the answer is insight is intact. That is a feature of neurosis. Trypanophobia is a fear of. Wonderful. Trypanophobia is a fear of needles. So read this case and tell me your diagnosis. So this case describes the classical clinical features of panic disorders. So panic disorder will be the best answer. Read the fourth question and give me your diagnosis. Wonderful. This is more characteristic of social phobia. How do you define an obsession? Yes, obsession is a distressing thought. Flashbacks are characteristic of which disorder? Yes, they are characteristic of post-traumatic stress disorder. Stage fright or performance anxiety is treated best with which drug? Wonderful. Propranolol is the drug of choice for performance anxiety. And the last question, after reading these two statements, tell me which option you think is correct. Wonderful. The answer is A. Both the statements are correct.